C. Abnormally large kidneys. D. Ascites. E. Abnormally large spleen. 61. A 3-year-old patient with Beckwith-Wiedemann syndrome presents for an abdominal U.S. study. The clinical indication states routine screening for malignancy. Which tumor is not commonly associated with the underlying syndrome? A. Rhabdomyosarcoma. B. Wilms tumor. C. Neuroblastoma. D. Renal rhabdoid tumor. E. Hepatoblastoma. 62. A 37-year-old woman with known history of inflammatory bowel disease presented to the gastroenterologist with worsening abdominal and systemic symptoms. All of the following extraintestinal manifestations of inflammatory bowel disease parallel the activity of the disease. Glycogen storage disease, polycystic kidney disease, and so on. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, Pa, Lippincott Williams and Wilkins, 2011. Tasker R.C., ETAL Oxford Handbook of Pediatrics. Oxford, Oxford University Press, 2008. 61. D. Renal rhabdoid tumor. Rhabdoid tumor is a rare, highly aggressive malignancy of early childhood. It is not related to Wilms tumor or rhabdomyosarcoma, and was recently recognized as a distinct pathologic entity. Its name is derived from its histologic appearance, which resembles that of a tumor of skeletal muscle origin, although a myogenic origin has not been proved. Rhabdoid tumor occurs exclusively in children, comprising 2% of pediatric renal malignancies. Approximately 80% occur in patients less than 2 years of age and 60% in patients less than 1 year of age, with the majority, 25%, diagnosed between 6 and 12 months of age. The median age at diagnosis is 11 months, with the lesion reported at up to 9 years of age. Low LH, ETAL pediatric renal masses, Wilms tumor and beyond. Radiographics. 2020:15. Disease except A. Erythema nodosum. B. Enteropathic spondylitis. C. Uveitis. D. Monoarticular peripheral arthritis. E. Pulmonary embolism. 63. (1585-603). 62. E. Pulmonary embolism. Extraintestinal manifestations of inflammatory bowel disease. Musculoskeletal system arthritis. Colitic type, ankylosing spondylitis, isolated joint involvement, hypertrophic osteoarthropathy, clubbing, periosteitis. Chapter 10. Test paper 5, answers. 285. Miscellaneous manifestations. Osteoporosis, aseptic necrosis, polymyositis. Dermatologic and oral systems. Reactive lesions. Erythema nodosum, pyoderma gangrenosum, aphthous ulcers, necrotizing vasculitis. Specific lesions. Fissures, fistulas, oral Crohn's disease, drug rashes. Nutritional deficiencies. Acrodermatitis. Enteropathica, purpura, glossitis, hair loss, brittle nails. Associated diseases. Vitiligo, psoriasis, amyloidosis. Hepatopancreatic biliary system. Primary sclerosing cholangitis, bile duct carcinoma. Associated inflammation. Autoimmune chronic active hepatitis, pericholangitis, portal fibrosis, cirrhosis, granulomatous disease. Metabolic manifestations. Fatty liver, gallstones. Associated with ileal-Crohn's disease. Ocular system. Uveitis/iritis, episcleritis, scleromalacia, corneal ulcers, retinal vascular disease. Metabolic system. Growth retardation in children and adolescents, delayed sexual maturation. Renal system. Calcium oxalate stones. Levine J.S., Borkoff R. 63. Which one of the following statements regarding penetrating aortic atherosclerotic ulcers is true? A. They can progress to pseudoaneurysm. B. They are contrast-filled outpouching surrounded by an intramural hematoma. C. They occur early in atherosclerotic disease. D. They can progress to aortic rupture. E. Intramural. R. Extraintestinal manifestations of inflammatory bowel disease. Gastroenterol hepatal, NY. 2011, 7, 4235-41. 63. C. They occur early in atherosclerotic disease. In a penetrating aortic ulcer, PAU, an atheromatous plaque ulcerates and burrows through the intima into the aortic media. This leads to hemorrhage into the wall, intramural hematoma. The mural hematoma may break through into the adventitia to form a pseudoaneurysm, or it may rupture. Ulceration of an aortic atheroma occurs in patients with advanced atherosclerosis. On imaging, a penetrating aortic ulcer can be distinguished from an atheromatous plaque by presence of a focal, contrast-filled outpouching surrounded by an intramural hematoma, which confirms the aggressive behavior of the lesion. The atheromatous plaque with ulceration, but without penetration through the intima, shows irregular margins, but no contrast material extends beyond the level of intima, which is frequently calcified, and no intramural hematoma is present. PAU can present with chest or back pain. Makura KJ, ETAL pathogenesis in acute aortic syndromes, aortic dissection, intramural hematoma, and penetrating atherosclerotic aortic ulcer. AJR AMJ Rentgenol. 2003, 181:30916. 64. B. Continued increase in size of follicle. Ovulation is sonographically determined by the follicle suddenly disappearing or regressing in size, irregular margins, intrafollicular echoes, follicles becoming more echogenic, free fluid in the pouch of Douglas, and increased perifollicular blood flow velocities on Doppler. Bacchus O. ETAL ultrasonographical and hormonal description of the normal ovulatory menstrual cycle. Acta Obstet Gynecol Scandinavia 1994, 73, 10-796. Chapter 10. Test paper 5, answers. 286. 65. A. Cholesterol granuloma. Cholesterol granulomas of the temporal bone can occur in the mastoid segment, the middle ear, and the petrous apex. Intramural hematoma signifies its aggressive nature. 64, a 26-year-old woman was referred by her family doctor to the infertility clinic for further investigations. She was scheduled to have a transvaginal US evaluation in the radiology department. All of the following are presumptive findings of ovulation on transvaginal ultrasound, except A. Reduction in size of the dominant follicle, B. Continued increase in size of the follicle. Chapter 9. Test Paper 5, Questions. 254. C. Loss of clearly defined follicular margin. D. Appearance of internal echoes in the follicle. E. Increased fluid in the pouch of Douglas. 65. A 26-year-old man with facial pain shows a large, well-demarcated expansal cystic lesion in the petrous apex with erosion of the internal auditory meatus. No associated erosion of the sputum. E. Hepatoblastoma. C. Loss of clearly defined follicular margin. D. Appearance of internal echoes in the follicle. E. Increased fluid in the pouch of Douglas. 65. A 26-year-old man with facial pain shows a large, well-demarcated expansal cystic lesion in the petrous apex with erosion of the internal auditory meatus. No associated erosion of the sputum is identified, and the tympanic membrane is intact. MRI reveals a corresponding high-signal lesion on both T1W and T2W sequences. What is the diagnosis? A. Cholesterol granuloma. B. Acquired cholesteatoma. C. Congenital cholesteatoma. D. Carcinoma of petrous temporal bone. E. Arachnoid cyst. They are the most common primary petrous apex lesions. Temporal bone CT reveals an expansal, sharply defined and often rounded mass of the petrous apex with cortical thinning and trabecular breakdown. The general appearance is that of a slowly progressive benign process. There is central soft tissue density without an internal matrix, a calcification, or residual septations. If the lesion is sufficiently enlarged, frank bony dehiscence is observed. On MRI, cholesterol granulomas are typically hyperintense on both T1 and T2 weighted sequences because of the accumulation of blood breakdown products and proteinaceous debris. Small lesions may be relatively homogeneous, whereas large lesions show more heterogeneity. Often cholesterol granulomas have a distinct hypointense peripheral rim on T2 weighted images due to hemosiderin deposition. After contrast administration, there may be subtle peripheral enhancement secondary to inflammatory response, but no central enhancement that would indicate solid tissue. Chapman PR, ETAL petrous apex lesions, pictorial review. AJR cyst. 66, a 6-year-old girl complains of pain in her left shoulder. X-ray shows a lucid lesion in the proximal humeral epiphysis. The lesion has sclerotic borders with specks of calcification within the lesion. What is the most likely diagnosis? A. Simple bone cyst. B. Aneurysmal bone cyst. A. Cyst, ABC. C. Non-ossifying fibroma. D. Fibrous cortical defect. E. Chondroblastoma. AMJ Rentgenol. 2011, 196, 3 supple WS 2637. 66. E. Chondroblastoma. Chondroblastomas are rare, benign, cartilaginous tumors that affect the epiphysis of children. On Mr. Images, chondroblastomas are seen as epiphyseal lesions with high T2 signal intensity surrounded by a halo of edema in the adjacent marrow and soft tissues. A characteristic thin, 1 mm, low signal intensity ring that corresponds to peripheral sclerosis is seen in more than 90%. Fluid levels similar to aneurysmal bone cyst, ABCs, are seen in 20%-30% of cases. Differential considerations include epiphyseal osteomyelitis and osteoid osteoma. Neuroblastoma metastasis and Langerhans cell histiocytosis can also affect the epiphyses. Simple bone cyst, SBC, fibrous cortical defects, and ABC affect the metaphysis. Jamie C. ETAL MR imaging of normal epiphyseal development and common epiphyseal disorders. Radiographics. 67. Which one of the following extraintestinal manifestations of inflammatory bowel disease is more likely to occur in patients with Crohn's disease than in those with ulcerative colitis? A. Sclerosing cholangitis. B. Pyoderma gangrenosum. C. Gallstones. D. Erythema nodosum. E. Pulmonary embolism. (2014) 34 2 for 4971. 67. D. Erythema nodosum pyoderma gangrenosum, PG, has been reported in 1% 10% of ulcerative colitis, UC, patients and 0.5% 20% of Crohn's disease, CD, patients. There is no significant difference between genders. There have been conflicting data regarding the distribution of PG among CD and UC, however there is no statistically significant difference between the two groups. Erythema nodosum is more common in CD than in UC. The occurrence of lesions parallels intestinal disease activity, and lesions frequently resolve when bowel disease subsides, thus treatment is usually aimed at the underlying bowel disease. At times, erythema nodosum can precede bowel exacerbations and can require treatment with oral steroids. Based on these findings, patients with idiopathic N should be evaluated for IBD. Levine J.S., Borkoff R., extra 68, a 33-year-old man presents with conductive hearing loss, pulsatile tinnitus and hoarseness of voice. CT showed erosion of the jugular fossa with upward extension of soft tissue mass into the middle ear cavity. MRI shows an intermediate signal mass on T1W images with high signal on T2W sequence interspersed with signal voids. Intense enhancement was seen on post-gadolinium images. What is the diagnosis? A. Carotid body tumor. B. Non-specified skull base tumor. C. Neurofibroma of the 12th nerve. D. Glomus jugulare. E. Osteoblastoma of transverse process of C2. Extraintestinal manifestations of inflammatory bowel disease. Gastroenteral hepatal, NY. 2011, 7 for 23541. 68. D. Glomus jugulare. About 80% of all paragangliomas are either carotid body tumors or glomus jugulare tumors. The typical CT appearance of a carotid body tumor is a well-defined soft tissue mass within the carotid space of the infrahyoid neck. The underlying hypervascularity of the tumor results in homogeneous and intense enhancement following intravenous administration of contrast material. Splaying of the common carotid bifurcation is very suggestive of a carotid body tumor. On high-resolution CT scans of the temporal bones, expansion and erosion of the jugular foramen characterize the glomus jugulare tumor. The tumor spreads along the paths of least resistance and is initially directed superiorly owing to the intrinsic weakness of this part of the jugular fossa. Subsequently, the hypotympanum, mesotympanum, and the sinus tympani are. Chapter 10. Test paper 5. Answers. 287. Invaded. Ossicular chain destruction is common. Inferior spread of the tumor produces infiltration of the IJV, internal jugular vein, and infratemporal fossa. Paragangliomas typically exhibit a low signal intensity on T1, weighted images, and high signal intensity on T2, weighted sequences. As with CT, homogeneous and intense enhancement is noted following the intravenous administration of contrast material. Multiple serpentine and punctate areas of signal void characterize the typical paraganglioma, with all Mr. sequences. These areas are variably distributed throughout the mass, and are believed to represent flow voids in the larger intratumoral vessels, salt and pepper appearance. C2. A 66-year-old man with acute onset of chest pain radiating to the back is sent for an urgent post-contrast CT of the chest to exclude aortic dissection. There is no evidence of a dissection or a penetrating aortic ulcer, but the scan is reported as showing an acute intramural hematoma in the descending thoracic aorta. All of the following are characteristic CT findings, except A, it is subintimal in location. B, it appears as a crescent of high density. C, MRI can help differentiate it from slow flow in false lumen of dissection. D, the aortic wall appears thinned out. E, they can progress to aortic rupture. Raueb, ETAL paragangliomas of the head and neck, radiologic pathologic correlation. Radiographics. 1999, 19:16-0532. 69, D. The aortic wall appears thinned out. Aortic intramural hematoma may occur as a primary event in hypertensive patients from spontaneous bleeding from the vasa vasorum into the media, or may be caused by a penetrating atherosclerotic ulcer. Intramural hematoma can also develop in blunt chest trauma with aortic wall injury. The hematoma propagates along the medial layer of the aorta. Consequently, intramural hematoma weakens the aorta and may progress either to outward rupture of the aortic wall or to inward disruption of the intima, the latter leading to communicating aortic dissection. Intramural hematoma can be distinguished from mural thrombus by identification of the intima. Mural thrombus lies on top of the intima, which is frequently calcified, whereas intramural hematoma is subintimal. On unenhanced CT, intramural hematoma is hyperdense. MR imaging aids in the distinction of slow flow in the false lumen of a dissection from no flow in an intramural hematoma. Dynamic post-contrast MR imaging is more sensitive for excluding slow flow in the thickened aortic wall, which would indicate aortic dissection rather than intramural hematoma. Makura KJ, ETAL pathogenesis in acute aortic syndromes, aortic dissection, intramural hematoma, and penetrating atherosclerotic aortic ulcer. AJR AMJ Rentgenol. 2003, 181:30916. 70, C. Hysterosalpingography. A 27-year-old woman is being investigated for infertility. Infertility. No anatomical abnormality of the uterus was identified on U.S. examination of the pelvis, and she was referred for further investigations to assess tubal patency. Patency of the fallopian tubes is best imaged by A. MRI B. Transvaginal USC, hysterosalpingography D. Sinohysterography E. Transabdominal US. Hysterosalpingography provides optimal depiction of the fallopian tubes, allowing detection of tubal patency, tubal occlusion, tubal irregularity, and peritubal disease. An imaging evaluation for female infertility typically begins with an assessment of tubal patency at hysterosalpingography, which may be followed by pelvic US. U.S. pelvic MRI or both to further characterize any additional findings. Steinkalea J.A., ETAL female infertility, a systematic approach.
इम्तियाज़ आमिर साहिब की है, बहुत पसंदीदा गज़ल है। आने की खुशी है अलग, जाने का गम अलग। आने की खुशी है अलग, जाने का गम
U.S. 71. A 10-year-old girl complains of severe pain in her left hip. Plain X-ray shows there is a 5 mm lucid lesion in the medial femoral neck. On MRI, there is a 2 mm central focus, which is iso-intense on T1W and high on T2W images. There is surrounding high signal on T2W image. Dynamic imaging reveals peak enhancement on arterial phase with early partial washout of the lesion. There is slower progressive enhancement of the adjacent bone marrow. What is the likely diagnosis? A. Osteoid osteoma. B. Osteoblastoma. C. Stress fracture. D. Cortical desmoid. E. Osteochondroma. Approach to radiologic imaging and diagnosis. Radiographics. 2009, 29, 513 5370. 71. A. Osteoid osteoma. Osteoid osteoma is a benign bone tumor that occurs most frequently in men and boys between 7 and 25 years old. Most patients experience pain that worsens at night and is promptly relieved by the administration of salicylates. Typical radiographic findings of osteoid osteoma include an intracortical nidus, which may display a variable amount of mineralization, accompanied by cortical thickening and reactive sclerosis in a long bone shaft. The nidus is round or oval and usually smaller than 2 cm. At CT, the nidus is well defined and round or oval with low attenuation. The nidus has low to intermediate signal intensity on T1, weighted images, and variable signal intensity on T2, weighted images, depending on the amount of mineralization present in the center of the nidus. Edema in adjacent bone marrow and soft tissue and joint effusion may also be seen. Enhancement of a hypervascular nidus may be seen at dynamic CT. Chai JW, ETAL radiologic diagnosis of osteoid osteoma, from 72. On a routine neonatal clinical examination, the pediatric registrar notes a simple sacral dimple at the natal cleft. It is blind-ended without any associated tuft of hair at the site of the dimple. What is the most reasonable subsequent management plan? A. No further management is required. B. Ultrasonography of the spine. C. Ultrasonography of the spine and cranial contents. D. MRI of the spine. E. MRI of the brain and spine. 73. A 4-year-old child. Simple to challenging findings. Radiographics. 2010, 30, 373749. Chapter 10. Test paper 5, answers. 288. 72a. No further management is required. Typical indications for spinal US in newborns and infants are skin-covered masses and midline cutaneous malformations of the back, e.g., dimple, hemangiomatous, or hairy lesion, which are suggestive of associated dysraphic anomalies of the spinal cord. Spinal dysraphism is often associated with tethering of the spinal cord. The US appearance of tethering is a low-lying or blunt-ended conus medullaris due to abnormal fixation of the spinal cord. Moreover, movement of the spinal cord and cauda equina can be evaluated with real-time US with M-mode scanning. Typically, the tethered cord is positioned eccentrically and demonstrates reduced or absent movement. Dorsal dermal sinus manifests as a small dimple or pinpoint osteum, which is often associated with an area of hyperpigmented, angioma-2 skin, or hypertrichosis and occurs in a midline location or rarely in a paramedian location. Soft tissue asymmetry and bone anomalies are common findings. Typical complications are infections such as recurrent meningitis, epidural or subdural abscess, and intramedullary spinal cord abscess. In particular, dorsal dermal sinus occurring in a paramedian location is often associated with an intraspinal dermoid or epidermoid cyst, which causes compression of neural structures with neurologic symptoms. For these reasons, dorsal dermal sinus has to be differentiated from simple sacral dimple or pilonidal sinus. The latter two anomalies do not extend to neural structures. Unsin KM, US of the spinal cord in newborns, spectrum of normal findings, variants, congenital anomalies, and acquired diseases. Radiographics. 2000, 20:92338. 73, B, supercon. Child falls onto an outstretched arm while on the playground. A radiograph of the elbow demonstrates the presence of a posterior fat pad adjacent to the distal humerus. There is no cortical defect or obvious fracture on the radiograph. What is the most likely underlying pathology? A. Osteomyelitis. B. Supracondylar fracture. C. Head of radius fracture. D. Clinoid fracture of the ulna. E. Septic elbow joint effusion. 74. Supracondylar fracture. The value of the fat pad sign is greatest as a predictor of an intra-articular disease process at the elbow in the absence of any radiographically visible bone abnormality. Fat pad displacement is independent of fracture displacement and comminution. This applies in particular to elbow examination in children, who often have very slight structural changes at presentation. Supracondylar fractures account for 60% of all elbow fractures in children, followed by fracture of the lateral epicondyle, 15%, and separation of the medial epicondylar ossification center, 10%. In adults, fracture of the radial head or neck accounts for just under 50% of all fractures at the elbow, followed by fracture of the olecranon, 20%, and dislocations and fracture dislocations. Goswami GK. The fat pad. All of the following structures are present in the center of the secondary pulmonary lobule, except A. Respiratory bronchiole. B. Pulmonary artery. C. Pulmonary vein. D. Lymphatics. E. Bronchovascular interstitium. 75. A 30. Pad sign. Radiology. 2002, 222:41920. 74. C. Pulmonary vein. The secondary pulmonary lobule, as defined by Miller, refers to the smallest unit of lung structure marginate by connective tissue septa. Secondary pulmonary lobules are irregularly polyhedral in shape and vary in size, measuring from 1 to 2.5 centimeters in diameter. Airways, pulmonary arteries and veins, lymphatics, and the various components of the pulmonary interstitium are all represented at the level of the secondary lobule. Each secondary lobule is supplied by a small bronchiole, pulmonary artery, and lymphatic branches centrally, and is marginate by connective tissue, the interlobular septa, that contain pulmonary veins and lymphatics. Web WR. "34-year-old woman with primary sclerosing cholangitis presents with worsening LFTs. All of the following are potential complications of primary sclerosing cholangitis in patients with inflammatory bowel disease, except A. Cholangiocarcinoma, B. Cholangitis. Chapter 9. Test paper 5, questions. 256. C. Cholecystolithiasis, D. Liver cirrhosis, E. Hepatic hemangioma. 76. A woman who was 32 weeks pregnant presented to the labor ward with acute onset of sudden severe abdominal pain developing over a period of 24 hours. Clinically, there was tenderness in the right lower quadrant with features of guarding and exacerbation with movement. Which one of the following statements regarding the use of MRI for evaluation of an acute abdomen during pregnancy is false? A. It has no known carcinogenic effects. B. It has no known teratogenic. WR. Thin section CT of the secondary pulmonary lobule, anatomy, and the image. The 2004 Fleischner lecture. Radiology. 2006, 239, 2320, 238. 75. E. Hepatic hemangioma. There is no association between PSC and hepatic hemangiomas. PSC is an idiopathic, chronic, fibrosing inflammatory disease of the bile ducts that eventually leads to bile duct obliteration, cholestasis, and biliary cirrhosis. A strong association with inflammatory bowel disease, especially ulcerative colitis, is noted 70% of cases. Although the cause of PSC is unknown, most experts believe it to be an autoimmune process because PSC may be associated with other autoimmune diseases such as retroperitoneal fibrosis, mediastinal fibrosis, and Sjogren syndrome. The rate of progression is unpredictable, with up to 49% of symptomatic patients. Chapter 10. Test paper 5, answers. 289. Eventually developing biliary cirrhosis and liver failure. Treatment is usually palliative and includes medical therapy with orally administered agents such as ursodeal or sodioxycholic acid, or endoscopic or percutaneous mechanical dilation of dominant strictures. Currently, orthotropic liver transplantation is the only curative therapy for PSC. Teratogenic effects. C. It can be used when an initial U.S. examination is equivocal. PSC. Vitellis KM, ETAL radiologic manifestations of sclerosing cholangitis with emphasis on Mr. Cholangiopancreatography. Radiographics. 2000, 20:95975. 76. E. Mr. Contrast agent is routinely used in pregnancy. The present data have not conclusively documented any deleterious effects of MR imaging exposure on the developing fetus. Therefore, no special consideration is recommended for the first versus any other trimester in pregnancy. Nevertheless, as with all interventions during pregnancy, it is prudent to screen women of reproductive age for pregnancy before permitting them access to MR imaging environments. If pregnancy is established, consideration should be given to reassessing the potential risks versus benefits of the pending study in determining whether the requested MR examination could safely wait to the end of the pregnancy before being performed. Pregnant patients can be accepted to undergo MR scans at any stage of pregnancy if the information requested from the MR study cannot be acquired by means of non-ionicing means. E.g., ultrasonography, the data are needed to potentially affect the care of the patient or fetus. During the pregnancy, or the referring physician believes that it is not prudent to wait until the patient is no longer pregnant to obtain these data. MR contrast agents should not be routinely provided to pregnant patients. The decision to administer a gadolinium-based MR contrast agent to pregnant patients should be accompanied by well-documented risk-benefit analysis. There should be overwhelming potential benefit to the patient or fetus outweighing the theoretical but potentially real risks of long-term exposure of the fetus to free gadolinium ions. Studies have demonstrated that at least some of the gadolinium-based MR contrast agents readily pass through the placental barrier and enter the fetal circulation. From here, they are filtered in the fetal kidneys and then excreted into the amniotic fluid. In this location, the gadolinium chelate molecules are in a relatively protected space and may remain for an indeterminate amount of time before finally being reabsorbed and eliminated. The longer the chelated molecule remains in the amniotic cavity, the greater the potential for dissociation of the potentially toxic gadolinium ion from its ligand. It is unclear what impact such free gadolinium ions might have if they were to be released in any quantity in the amniotic fluid. Certainly, deposition into the developing fetus would raise concerns of possible secondary adverse effects. The risk to the fetus of gadolinium-based MR contrast agent administration remains unknown. It may be harmful. Canal E, ETAL ACR guidance document on equivocal. D. The result of the study potentially affects the immediate care of the mother or fetus. E. MR contrast agent is routinely used in pregnancy. 77. Which technique reduces artifact from hip prosthesis during MRI? A. Use of a magnet with a higher field strength. B. Use of FSE imaging rather than G imaging. C. Alignment of prosthesis perpendicular to the magnetic field. D. Using a narrower bandwidth. E. Use of the magic angle. 78. A19. MR Safe Practices, 2013. J. Man Res on Imag. 2013, 37, 35013. 77. B. Use FSE imaging rather than G imaging. Several strategies help in reduction of susceptibility artifact from hip prosthesis. Some of these are as follows. Reduced magnetic field strength, increasing bandwidth during slice selection and readout, increasing matrix size. 512 pixels maintain good SNR, signal to noise ratio, by increasing number of excitations. Next, number of excitation. Use spin echo, FSE, instead of gradient echo, GRE, where possible stir for fat suppression. Spectral frequency selective fat suppression performs better in a homogeneous field. Use of shorter echo spacing. Use smaller water fat shift use. Thinner slices. Chapter 10. Test paper 5, answers. 290. Align prosthesis parallel to the magnetic field. Use view angle tilting, VAT. Hargreaves. Year-old man shows a large mass in the nasopharynx on CT sinuses. Post-contrast images confirmed an intensely vascular mass extending into the pterygopalatine fossa and infratemporal fossa with forward displacement of the posterior wall of the maxillary sinus. Coronal images showed erosion of the base of the pterygoid plate. What is the diagnosis? A. Inverted papilloma. B. Nasopharyngeal carcinoma. C. Juvenile angiofibroma. D. Lymphoma. E. Midline granuloma. Hargreaves B.A., ETAL metal-induced artifacts in MRI. AJR AMJ Rentgenol. 2011, 197, 354755. 78. C. Juvenile angiofibroma. Juvenile angiofibroma presents characteristic imaging signs. The diagnosis by CT is based upon the site of origin of the lesion in the pterygopalatine fossa. There are two constant features. 1. A mass in the posterior nasal cavity and pterygopalatine fossa. 2. Erosion of bone behind the sphenopalatine foramen with extension to the upper medial pterygoid plate. The characteristic features on MRI are due to the high vascularity of the tumor, causing signal voids and strong post-contrast enhancement. Lloyd G. ETAL imaging for juvenile angiofibroma. J. Laringal Otal, 2000, 114:72730. 79. A. Mucinous cystadenoma. The solid fibrous component of fibroma, fibrothecoma, and cystadenofibroma characteristically demonstrates very low T2 signal intensity. With T1 weighted sequences, fibrothecomas demonstrate non-specific hypo to isointensity with mild enhancement following the intravenous administration of a gadolinium chelate. Brenner tumor is an uncommon epithelial stromal tumor. Tumor. 79. A 41-year-old woman was referred for a pelvic US by her family doctor after she complained of pelvic heaviness. US revealed a complex primarily solid-looking mass in the adnexa, which was thought to be ovarian in origin. A pelvic MRI was scheduled for further evaluation and characterization. All of the following adnexal masses usually present on both T1W and T2W MR imaging with low signal intensity except A. Mucinous cystadenoma. B. Brenner tumor. C. Ovarian fibroma. D. Fibrothecoma. E. Exophytic leiomyoma. 80. A neonate tumor. The fibrous components, as well as calcifications, when present, are markedly hypointense on T2 weighted Mr. images. Exophytic subserosal leiomyoma have low T2 signal with low to intermediate T1 signal on MRI. The bridging vessel sign represents tortuous vascular structures passing between the uterus and the lesion and may be seen at US. However, this sign is most clearly depicted at gadolinium-based contrast material enhanced T1 weighted imaging or T2 weighted imaging, which nicely demonstrate vascular flow voids. The bridging vessel sign confirms that the lesion originates from the uterus and excludes an ovarian origin. Mucinous cystadenomas show a complex cystic structure with high signal on T2 weighted images. Cause-Hopper A. ETAL T2 hypointense adnexal lesions, an imaging algorithm. Radiographics. 2012, 32 for 104764. 80. B. The umbilical arterial catheter, UAC, tip at the on the intensive care unit is referred for a chest and abdominal radiograph. There are several support lines and tubes in situ. Which of the following is inappropriately located? A. The umbilical venous catheter, UVC, tip within the inferior vena cava, just below / at the level of the right atrium. B. The umbilical arterial catheter, UAC. At the L1 vertebral level, the umbilical venous catheter, UVC, tip should lie within the inferior vena cava, just below or at the level of the right atrium. The tip of a UAC should be optimally positioned between the T6 and T9 levels so that it does not interfere with major upper abdominal arterial branches. The endotracheal tube, ETT, tip should lie at the T2 vertebral level. The nasogastric tube, NGT, tip should be located below the diaphragm within a gastric air shadow. The central venous catheter tip should be located at the cavoatrial junction. Jane Jane S.N. A pictorial essay, Radiology of Lines and Tubes in the Intensive. UAC, tip at the L1 vertebral level C. The endotracheal tube, ETT, tip at the T2 vertebral level D. The nasogastric tube, NGT, tip located below the diaphragm within a gastric air shadow E. The central venous catheter tip located at the cavoatrial junction. Chapter 9. Test paper 5, questions. 257. 81, a 66-year-old man presented to the A&E department with progressive chest tightness and shortness of breath. ECG was normal and inflammatory markers were normal. Chest X-ray was abnormal and an HRCT was requested. HRCT showed a diffuse interstitial pattern of small nodular opacities. All of the following may be associated with this finding, except A, sarcoidosis, B, talcosis, C, scleroderma, D, hypersensitivity pneumonitis, E, small nodular metastasis. 82, a 37-year-old woman with known history of inflammatory bowel disease presented to the gastroenterologist with worsening abdominal and systemic symptoms. All of the following are extraintestinal musculoskeletal manifestations of inflammatory bowel disease, except A, neuropathic osteoarthropathy, B, enteropathic spondylitis, C, hypertrophic osteoarthropathy, D, sacroiliitis, E, monoarticular peripheral arthritis. 83, on your routine MR reporting session, a lumbar spine shows normal alignment and multilevel low signal on both T1 and T2 in the intervertebral disc centrally, with disc space narrowing. What is the most likely diagnosis? A, CPPD, B, achronosis, C, amyloidosis, D, renal osteodystrophy, E, gout. 84, a 64-year-old man with nasal obstruction and bloody nasal discharge showed a large heterogeneous mass in the nasopharynx on CT sinuses. There was loss of normal parapharyngeal fat planes with non-enhancement of the ipsilateral jugular. Intensive Care Unit. Indian J. Radial Imaging. 2011, 21, 318290. 81, C. Scleroderma. There are 3 possible HRCT distributions of nodules, perilymphatic, random, and centrilobular. The causes of perilymphatic nodules include sarcoidosis, lymphangitis carcinomatosa, silicosis, amyloidosis, rare, and lymphoid interstitial pneumonia, rare. The causes of random nodules include miliary TB, miliary spread of fungal infection, metastasis, and sarcoidosis, rare. The causes of centrilobular nodules include endobronchial infection, endobronchial tumor, aspiration, respiratory bronchiolitis, interstitial lung disease, RBILD, hypersensitivity pneumonitis, HP, histiocytosis, vascular causes, edema and hemorrhage, and talcosis. Elliker B. ETAL high-resolution computed tomography patterns of diffuse interstitial lung disease with clinical and pathological correlation. J. Brosnamal. 2008, 34, 97, 15, 44. Chapter 10. Test paper 5, answers. 291. 82, A. Neuropathic osteoarthropathy. Extra 81, a 66-year-old man presented to the A&E department with progressive chest tightness and shortness of breath. ECG was normal and inflammatory markers were normal. Chest X-ray was abnormal and an HRCT was requested. HRCT showed a diffuse interstitial pattern of small nodular opacities. All of the following may be associated with this finding, except A, sarcoidosis, B,